We now show the physical exam of the heart.
Okay, so physical examination consists of 4 areas: inspection, palpation, percussion, and auscultation. So on inspection, I look. I know where the heart is. It's already drawn out. It would make sense that I would look in the sternal area. If I had any problem where the right heart was having problems, I might see some heaving of the sternum, it moving up at you. Equally, if I had a problem with the left ventricle, which we described as the apex of the heart, we could understand that I could see a heaving over in this area, but also I could see it move over laterally. As the heart started to fail, it would start to get larger. So I look in every area that I described: the aortic, pulmonic, Erb's point, tricuspid, and mitral area. I look at the apex and I look at the right border of the heart. Then I touch. That's the second area. I put my hand across the precordium. So this is the area that's called the precordium of the heart. And I am feeling to feel if I feel any what's called a thrill, which feels like a kitty cat purring underneath the skin. That would be associated with a significant murmur. And then we move on to percussion. We do not percuss the heart borders anymore, so we will discuss that when we get to the abdomen. And then finally, we move to auscultation. So you now have to recall, what am I listening to? I'm listening to the valves closing. Remember, we have 4 valves. So I'm listening to S1, S2, or lub-dub. Now, S1 is systole. That is when blood is pumping out down through the toes, which means the aortic and the pulmonary valve are opened. So the noise I'm hearing on S1 is the closure of the tricuspid and the mitral valve. These are also called AV valves because they lie between the atrium and the ventricle. Therefore, where those valves are, I'll hear that sound louder. So here is the aortic and the pulmonic. Those valves close during diastole. Diastole is when the heart is resting. Well, the heart rests once the blood goes out into the periphery, so therefore I will hear the sound of the aortic and the pulmonic valve when they close. So when you listen to the heart, you're going to hear in the aortic area both sounds. You're going to hear S1 and S2, but S2 will be a little bit louder for you because that door is closing during diastole. I will move it over to the pulmonic area. I will hear S1 and S2. But again, S2 will be heard a little louder than the S1. Now that Erb's point, that part I told you about, the third intercostal space on the left sternal border, this is a palate cleanser, if you will. This gets you back to understand S1 is the same as S2. I move down to the tricuspid area, and in this area, now I hear the S1 louder than the S2 because that's where the valve is closing, and the same for the mitral area. There are 2 positions you must put the patient in before you can say there's no murmur. What are they? For the aortic and the pulmonic area, I must lean the patient forward because this will accentuate aortic and pulmonic murmurs. And to glean whether or not there is a tricuspid or a mitral murmur, I must put the patient in left lateral position and listen in the tricuspid area and the mitral area. And the mitral area is also the area where I will hear gallops, which we will discuss later on because in adults they're pathological.
We now show physical exam of the respiratory system.
So you recall that physical examination begins with inspection. I inspect to see whether or not he's got any nasal flaring or mouth breathing. I look to see if the trachea is midline. The trachea will shift towards or away from an area of pathology. You follow down to the trachea and you remember at the angle of Louis, the right main stem bronchus is shorter, stouter, and more vertical. So again, this is the area that we worry about related to aspirations. I look at the shape of his chest and I notice whether or not he has any what we call retractions. That is, the intercostal spaces, are they sucking in when he breathes out? Are they bellowing out when he exhales? You could also see those retractions in the supraclavicular area. You could see it infraclavicular area. He has none. So I'm noticing whether or not also he has any asymmetry. This side of the chest should be the same as this side of the chest. I also look at the shape of his chest, anterior to posterior. If I was to measure the distance front to back, that should be 1/2 of the distance laterally. So you notice the shape of the chest, anterior, posterior, as compared to lateral, he should be twice as large, okay? Because when you start developing pulmonary diseases, the lung starts to develop blisters on it, for example, and the shape of the chest changes where anterior, posterior is the same as lateral, and we would call that a 1-to-1 approximation or barrel chesting. I also look to see if he has any deformities, particularly of the sternum. The sternum can wing up at you. We'll call that a pectus carinatum, or it can wing down. We would call that a pectus excavatum. These are things that you notice that tell me there might be a problem with his ability to take a breath in and out. So on inspection, I'm looking at all those areas. Next, what do? Next, I touch. I touch to see if there's any area of tenderness. Remember, this is not real rib, this is costal cartilage. Sometimes that becomes inflamed, and by simply touching it, the patient would tell me that he's in pain, and I would know we have inflammation of the costal cartilage. So I'm just touching to see, is there any area of tenderness? Then I move to percussion. Percussion is me pushing a sound into his lung that goes in about 2 inches. And then the sound coming back, I make some determinations about. Remember, the lung is an air-filled organ. So an air-filled organ, if I tap it, will make a sound called resonance. This is what it sounds like. That's resonance. Now, if I tapped a solid organ, it would sound dull. So I need to make some determinations about his lungs. So what I can do is I can tap down the lung until I hear a difference. And when I hear the difference, that means to me that his lungs have ended and I've hit something else. Now, what do I want him to do? I want him to see if his lungs really are good. Remember, we discussed this. Do you remember what we call that? The diaphragmatic recess. If he takes a good deep breath in, the diaphragm will pull down and his lungs should descend further. So we're going to try again. I'm going to say, take a deep breath and hold it, remembering that he stopped right about here. Listen to the difference now. Deep breath in and hold it. Do you hear the difference? He moved down now to below that recess, so his lungs were able to come down. So that tells us that he has good diaphragmatic motion. Now I'm going to listen to lung sounds. You can listen anteriorly, you can listen posteriorly, but the kick is you have to listen and make sure that you're getting the right middle lobe. Remember, start the stethoscope. We're going to have the patient open their mouth and take a deep breath in and out because it's important that I hear turbulence. And as he breathes in and out, I move the stethoscope, comparing one side to the other, moving down. As you move down the lung fields, it becomes harder and harder to hear. The lungs become softer and softer again. So let's just look at our anatomical drawing. Can you see that I would be able to assess his upper lobe pretty well, upper lobe pretty well, middle lobe pretty well? Look at this little area of lower lobe. So obviously, we want to listen to all the lobes, and you can see posteriorly, we have a good amount of upper lobe, we have a great amount of lower lobe. but no right middle lobe. So if you're going to listen posteriorly, you will start and listen, comparing one side to the other, move down. Notice I'm not putting my stethoscope over the scapula or the spine. Compare one side to the other, move down, compare one side to the other, move down, compare, and go down. You notice you're not going down forever because we know the lungs end about T10. See that? So we are only, if you think about where the patient's waist is, I usually say 2 finger breaths above, that's where the lungs are ending. But where was the right middle lobe? I missed the right middle lobe, so I need to take the patient, lift the arm up, take my stethoscope, and put my stethoscope anterior to the mid-axillary line. When you turn them around, can you see where I am? I am in the right middle lobe. So posteriorly, you can hear upper lobe and lower lobe, but no middle lobe.